like Bruce Willis and Die Hard when I'm like, welcome to the party, pal. They're like, confinement. I was like, welcome.
Welcome to the Crit Chat Podcast.
Or as I'd like to call it, Critical Chats Podcast.
Where we talk about the new and exciting developments in the critical care world and get to know the providers behind the medicine.
Our guests have a range of clinical experience and include doctors, advanced practice providers, nurses, and respiratory therapists. You're here with Sneha, a critical care PA.
And Sheila, also a critical care PA.
Your podcast hosts. Today's guest is Dr. Mullen, who has been a physician since 1995 and a triple board certified at that in emergency medicine, critical care, and pulmonary medicine. Let's just say she's the person you want caring for you if you're very ill. Welcome, Dr. Mullen, to our first episode of the Critical Chats Podcast.
Welcome.
Well, thank you. I'm very honored to be with you, Sheila and Sneha. I'm very honored to be asked to speak to you all, and you're speaking about two of my favorite topics in the whole world. Critical care and sepsis, so I'm really excited to be part of that. So all of y'all out there, slam sepsis.
Excellent. I'd like to start by asking you some preliminary questions about yourself. What about how you segued into this field of medicine?
Okay. Well, just so you guys know, I never was going to go into medicine. I was going to teach biology and chemistry, and I did pre-hospital medicine as a college student, and as part of that, you have to go to the emergency department and see what they do. I was like, okay, yeah, I got to go to the emergency department, and I just got bitten by the medicine bug. I was like, this is cool. I watched a community doctor take care of a gunshot wound to the chest, a child with a laceration, the parent who fainted while the child was getting the laceration taken care of, a psychiatric emergency, and she was amazing. And I said, I want to do that. So I went to medical school wanting to do emergency medicine, and then I fell in love with internal medicine. And I'm like, emergency medicine, internal medicine. And I did some investigating, and I found out you could do emergency medicine and internal medicine in one big residency, 5 years. So I ended up at Henry Ford Hospital, which is an amazing, amazing hospital. 5 years, emergency medicine, internal medicine. And I always had a love of critical care. I was like, what's my elective? ER, I'm doing SICU as my elective. I always chose, okay, medicine, what am I going to do? I'm going to go do MICU. Whoop, another elective, MICU. So I really enjoyed critical care. But I knew I was going to do emergency medicine, but critical care was nice to have, and it was always a passion of mine. Came here, worked as an emergency physician, and I actually still kept my internal medicine roots. I actually worked as the equivalent of the TCT attending. I moonlighted. I enjoyed admitting patients. I moonlighted over at Marlborough Hospital. I loved it, but I always wanted to do critical care medicine. And the opportunity came in 2014. The pulmonary critical care folks were willing to take me on as the probably one of the world's oldest fellows. I've been doing emergency medicine for 14 years. So 47-year-old me learned how to get up again and take call. So, but I loved it. I loved pulmonary. I loved critical care. I really was living the dream, but part of that came from doing emergency medicine, internal medicine, and just my love of critical care. But I really want to extend a thank you to the Pulmonary Critical Care Fellowship here for taking an old lady to try and keep up with those young kids. So, and I had a lot to learn, especially in pulmonary clinics. So to all my mentors out there, I'm grateful. So, but it was a long journey, and not exactly your straightest route in the world, but it was great, and I've loved it ever since. I really have. It's been a privilege.
I remember someone said, the fellow is going to be here. And I'm like, what fellow? The critical care fellow, the pulmonary critical care fellow. And I go look, and I'm like, that's Dr. Mullen. She's not a fellow. She's an attending. And then you were a fellow at the time. So I remember that. I was like, what is she doing here? So you're quadruple board certified.
I am. I'm still holding on to internal medicine barely by my fingernails, because that's hard. You should see what they have you they have you do. But as Sneha and you were saying, the big ones are EM, critical care, and pulmonary and internal medicine folds into that.
That's amazing.
That is amazing.
But it's
we bow to you.
We do. We all do. And I'm sure everyone at our hospital would agree that we do look up to you a lot.
Absolutely.
Well, it's a team sport, and y'all keep me out of so much trouble you'll never know. But no, it's been a privilege to be a fellow, and I'm just going to do a shout out to all the attendings who were kind enough to put up with me.
I'm sure they recognized how wise you were and how much of an addition you were, and I think it's very apparent now, just based on how you practice and how you treat even new PAs like myself. It's very apparent that you're really well appreciated here.
Yes,
so
we can count on you when something is wrong.
Yes.
Well, as I like to joke, I go under the bus before you do. I stand between you and the bus. I promise. My father taught me. He's an old military guy. He goes, "Take care of your people." I go, "Got it, Dad. Got it, Colonel."
And here you are taking care of your people, right?
Right, you are.
All right, so thank you for sharing all of that. We have a few questions about sepsis. That's kind of the topic that I think we all identified that you really enjoy speaking about. So we're going to kind of segue into that next. I wanted to start out by asking you if there's anything new in the sepsis world or anything that we should all be aware of as new practitioners and also as more experienced practitioners.
That's a great question. There is a lot going on, and I'm going to refer to my experiences at the Society of Critical Care Medicine. And as we were talking before the podcast, I think some of what's old is new again. So particularly the French are going back to looking at the microcirculation, and they are pushing back on the capillary refill. We had the ANDROMEDA-SHOCK study. We now have, they're working on, I believe, ANDROMEDA 2. But again, as low tech as that is, I like to say low tech is not no tech. So again, capillary refill modeling, they're looking at what is going on with the microcirculation. Should we be resuscitating the microcirculation, and should we be resuscitating the mitochondria? And along those lines, they were actually going back to my favorite. There really is something about thiamine. I kind of felt like Bruce Willis and Die Hard when I'm like, "Welcome to the party, pal." They're like, "It's thiamine." I was like, "Welcome." I was like, "That's what we do here." But anyway, looking at how can we support the mitochondria. So I think that's up and coming. I think there's some new movement in Vasopressin. There really is something special about Vasopressin, and I'm hopeful. We are seeing some movement, I think, on our methylene blue, and maybe hydroxycobalamin. Though again, I think so. I'm hopeful from that standpoint. Other things that we need to think about that we're going to be looking at is probably from a genetic standpoint, that we're probably going to be tailoring sepsis for. Towards genetics. So we're looking at in pediatrics, because we know there's some subsets of people that do worse with sepsis than others, and there may be a genetic component, and people are starting to filter that out. So I think that's some of the newest on the horizon, and I still have some hope for the right beta blocker for our patients, more about controlling heart rate. And I think there's another new frontier about sepsis in the heart. I've got a real interest on, because that's where people a lot of times die in sepsis. I think we've all seen it, where they all of a sudden have an acute cardiac arrest. They finally gave out. So I think that's another frontier. If I ever get my act together, I'm going to do a review article on sepsis in the heart, but it's so broad. So that's a challenge. But I think that's just an introduction. Then I think as we were talking SCCM, there might be a new study coming out. I think they're just recruiting, but they're looking at Metformin to attenuate acute kidney injury in diabetics with sepsis. So that may be something that's coming out. It's definitely not ready for prime time. Nobody start giving out Metformin to our patients. And then there may still be something about statins as well. There is something about inhibiting the bacterial cell wall with the elements of the statin. So again, there's some interesting frontiers out there.
Very interesting. Yeah. Thank you. Actually, going off of that, the 2 points that you brought up, one was about vasopressin. It's just so interesting to me that, you know, even before I was practicing, maybe when you two were practicing, the first pressor wasn't necessarily norepinephrine. You know, we were using other pressors. Yeah. So it's interesting that vasopressin is now coming into the picture. Is that more of kind of what's coming up with the new research? Is using that as a first pressor?
I think we need to look at the dosages. I still think it goes together with the norepinephrine per se, but there's something very interesting that vasopressin may protect the kidney, and that comes from the VANISH study. Okay. The VANISH study was vasopressin plus or minus steroids, and it wasn't in regards to the most positive study, like vasopressin's great, but out of that study there's something about vasopressin in the kidney, and I've been noticing that. Now, again, use vasopressin wisely out in the ICU, but there may be something kidney protective about vasopressin. Matter of fact, people out there may see me practice where I'm like, leave the vasopressin on because there's probably vasopressin deficiency, and take the norepi off first. I see. And so I still think it's an adjunct, but there's a recent article out there that I have to review a little bit better. There's also a question about, you know, what dose should we be using? The original vasopressin dosing was 0.04. We have the VAS study doing 0.03. But there's a suggestion like, should we be doing weight-based vasopressin? And again, when I've got my right heart failure patients, I'm a little bit more aggressive because vasopressin may help the right heart and it may not hurt. So I do tend to push it when I get right heart failure and sepsis, which I wouldn't wish on anybody. Right. I do push my doses a little bit more on the vasopressin. When I'm pushing hard with vasopressin, I go with the dosing from the VANISH study. Keep in mind the VANISH study primarily did just vasopressin. It wasn't vasopressin and norepinephrine. So I'm pushing the envelope a little bit when I do it. But the VANISH study went up to 0.06 units per minute. So again, I'm going a little bit rogue. But like I said, I'll go under the bus before y'all do. And I always tell y'all, if I have you guys give 0.06 units of vasopressin, I'll tell you guys, I'm writing that on my note. I'm going to own it if somebody hates that idea. Right. So I do that in the right circumstances. But there is something I think about the kidney and vasopressin. And again, there's a new article out in JAMA. I think it's only a year old about how we should be dosing our vasopressin. I just need to look at that in a little bit more detail. So I think it's called, I'm not mistaken, I think it's called OVISS. I think it's OVISS. It just came out in JAMA. I think it's only a year old because I was reviewing that with the neurocritical care folks.
Well, I certainly have a lot to read now. So thank you for providing all the names of those studies.
I have a question about some common pitfalls that you see new providers do and you would like to highlight.
Sure. And again, I like to highlight the fact that sepsis doesn't play fair, and I continue to miss sepsis because it doesn't play fair. But for those new team members out there, a couple of pitfalls. This one across the board, including myself, I've had egg on my face about vague sepsis. So there's a problem with sepsis not looking like sepsis. It's a concept of vague sepsis, and that's been actually well quantified. So just because they don't have a fever doesn't mean they don't have sepsis. And unfortunately, just because they don't have a white count doesn't mean they have sepsis. So for new team members, if the hypotension's not explained, say to yourself, could it be sepsis? I mean, is that AFib with RVR not responding because they're septic with their UTI? So I think that's one big thing. And just respect that things overlap. Can you have sepsis and CHF? Yeah. So I think that's one of them. Another challenge is it's the easiest intervention we do, but that's antibiotics. And that is more... there's a delay for this, there's a delay for that. But yeah, sure, I want to do the cool central line and art line, especially when you're, a younger team member, I want to get that. But I think the issue will be the antibiotics are so important. And this is the one time so a couple things with pitfalls. First is fast. So slam it in. You want the most fastest, broadest antibiotic in. And that's where I love the nurses. I'm like, okay, which one can I drill in? Because I need to drill it in now. And then one of the pitfalls is you want to do everything right. And I'm not telling anybody out there to go rogue. Like, don't say, I'm not doing blood cultures or hang the blood cultures. But there's a time if there's a delay. And I've loved my nurses who came to me and said, we've really tried, but we are not getting those blood cultures. I'm like, okay, well, if you've got that 22 gauge in their big toe, we're slamming in cefapime, we're slamming in fluid, and we're going to fix that central line deficit. So again, simple stuff, but again, keep it simple. The antibiotics don't delay antibiotics. And then just a couple other things for the new providers out there. Just reassess. Okay, it's like, great, I've done this. But again, don't turn your back on those sepsis patients. They'll turn on you. Yes, I know the hard-working stat nurses, they are on the floor, but don't turn your back. So just like you do PALS and BLS, reassess. And then a real challenge, and I think we had a really nice discussion yesterday in critical care conference about lactate. So if you have a high lactate, that means you have to go to work. That means where is it coming from? Right. So for new team members out there, lactate of 4 does not equal fluids. Lactate of 4 means you have to say to yourself, is it a cardiac problem? Is it a hypoperfusion problem? Or, is it a preload problem? And that may be the right thing for the patient, but please, you gotta, I have a slide when I teach sometimes called, wherefore art thou lactate? It's like, where is it coming from? Because it can come from many places. And actually lactate of 4, we all know, doesn't go to the floor, but, or need some more, but or out the door. But that being said, you got to say, where is it coming from? Because it could be heart failure related, or it could even be heart rate related. I had somebody send me a lactate of 9, and I said, why is their heart rate 30? I go, yeah, that's cardiogenic shock, and we shall do something about that, but they are not getting fluids. Yeah. So again, just those I think are some of the big points for those hard working. Yeah, absolutely. Yeah. Did they seize with their meningitis? That's right. Or their low sodium.
I know. Yeah.
Then you're definitely slamming antibiotics into them.
Exactly. I've drilled ceftriaxone, and actually before I intubated somebody, I just grabbed the bag of ceftriaxone and squeezed, like, now. You're done.
Through the AT tube, maybe?
No, it's not. But I was like, we had a good IV, and I was like, die, bacteria, die. Bam!
Okay.
Here, have some ceftriaxone and choke on it.
I do. So going off of the whole fluids question, there are certain instances, and you kind of touched upon, if they're in cardiogenic shock, of course you're not going to slam fluids into them. But I find it kind of interesting, the Septic, the Surviving Sepsis campaign. So it's a generic 30 cc's per kg, excluding, kids and young children. But for all adults, 30 cc's per kg. That's right. I'm a child-sized human. So the 30 cc's per kg, I find it very interesting because I wonder if it's applicable to every adult-sized human.
That is a great question, and if you need me to include this with the podcast, I don't own stock in this article, but there is a great article by Dr. Rivers and Jane called Hydrophobia is Unwarranted, but Drink Responsibly. So first and foremost, I think 30 mLs per kg is appropriate in a lot of people. So you're 20 or you're 30-year-old, they can take it. Okay, it was taken as a conglomerate. It used to be 20 mLs per kg, it used to be 40 mLs per kg, and I think they settled on 30 mLs kg because there is a fight about where did this come from. It's from a conglomeration of different articles. It's not a bad idea, but I think, again, as the article said, you have to drink responsibly. So my approach to fluids is resuscitate and then reevaluate. I know they all need fluid. And Rivers will talk about this. When you first see a septic patient, they're mostly in what's called the ebb phase. So they've lost some fluid. They've had exogenous losses. They've been vomiting. They've been diarrhea. They need some, but how much they need gets into a little bit of a challenge. But we know the sooner we give them fluid, they do better. But again, they may not, to your point, Sneha, they may not all need 30 mLs kg. So what I usually say is, give them something up front and then reevaluate. And that reevaluation doesn't need to be a high tech. I joke with the residents about, low tech is not no tech, but you can look at the jugular vein. You can look, I gave fluid, I did this, which goes along with reassessment. I tend to like the ultrasound when I can get it. But again, there are times you're assessing somebody in the one of those hallway beds on the 5th floor or something like that, or some alcove, and that's not going to happen. But I think you want to give the fluid and say, is this the right patient for 30 mLs per kg? I think the nice thing is that the people that oversee us for these guidelines have actually gotten with the guidelines and realized, hey, if grandma looks like a science fair volcano and she's spewing up pink phlegm, we're not going to give it. Now we can document that. One interesting point I wanted to make was from the Clover study, because I think the Clover study from 2023 illustrated this point, which is the upfront fluid is the money fluid. Now, we may not know how much to give, but in Clover's, before they randomized people to liberal and restrictive, every single one of those patients got almost the same amount. When you look at both groups, if I remember correctly, had 2,050 mLs, both going into whether restrictive or limited, and they got that within the first 4 hours. That's where they got the resuscitation. Right. Why was it negative? Because they got their upfront resuscitation. So the restrictive versus the liberal didn't change things as much, but they got something upfront. So I think what we have to say is there are going to be people that can give 30 mLs per kg, but if they don't, based on your assessment, we just document it and move on. And I spend time doing that. I had a gentleman that I said, I think this guy's got CHF on top of that. There's no way I'm giving this guy fluid, and I'm documenting that. And I've had some surprise ultrasounds with, I had some gentleman that probably had an ejection fraction of 10%. It's amazing what a little ultrasound will do. I'm like, whoa, Nelly, no fluid for you. Right. But again, you don't necessarily need to use an ultrasound. If you look at the patient, you don't like it, or you give a trial and you're like, hey, they got worse. Again, use what you have, not what you want. But I think you do have to resuscitate up front and then reevaluate. And again, I think the Clover study shows it's the fluid in the first couple of hours. There's even an article that the Rivers and Jane study quotes by Leishman that showed if you just started giving fluid in the first 30 minutes, it wasn't how much, it's like you started. And again, I think, I like this phrase, patients are like snowflakes, ain't one the same. I think you have to tailor it. There is going to be that subset, 20-year-old with pyelo, etc. Let it rip. They can probably take it. But I think in most cases, you are going to have to say, I'm going to give you some fluid, I'm going to reassess. And then just a quick caveat too, ideal body weight. If there's a BMI that's high, that also gives you a little bit of protection, like a BMI of 30 or greater. You can use the ideal body weight instead of using the 30 mLs per kg. Again, I like the option of hydrophobia, drink responsibly.
That's right.
I like that. That's actually that's something good to look by. I hadn't heard that before.
It's a great article. I think it's a common sense approach to fluids, but he talks about the ebb phase. And that's early sepsis. And then 12 hours later, when we're getting them in the ICU, they're in the flow phase. They might even need diuresis. But I think it's also about timing. Where is the patient on that timeline with the fluids? And then for our folks out there, occasionally, despite you doing everything right, they might go into flash pulmonary edema. Yes. And that is because, I don't want anybody to feel bad out there, that is because there's a phenomenon in sepsis where the capillaries get stripped of their protective lining, the glycocalax. And the patient needed the fluid, but they flashed because the capillaries couldn't hold on to it. So again, I don't want anybody ever feeling bad about, oh my gosh, I sent them into pulmonary edema. Probably it's a physiologic phenomenon that the capillaries are truly leaky, but there's a known phenomenon in sepsis. It doesn't play fair. And the glycocalax gets stripped from the vessels and the fluid just leaks out. You were doing the right thing. So again, for all those folks out there, just make the best decision at the time with the information you have. And if you do that, I like to joke in Return of the King, you bow to no one.
And I feel that's actually a very good point to bring up, because I think as new practitioners, sometimes you can be a little bit nervous about, this is a lot of fluid for someone who potentially is in heart failure. Yeah. And I think you're right in that instance. You have to make the decision, because if you don't make any decision at all, then you've gone off and you've lost your opportunity. So I think it's a good point to, you do it right away. You do what you, based on the information you have, do what you can, and then later that you have methods of fixing possible flash pulmonary edema. Right,
but I like to say there's no Monday morning quarterbacking in sepsis. We're making some really hard decisions. We're trying to make the best decisions, and again, sometimes the information isn't there. And again, I've defended many a resident. I'm like, no, that was right. I've had a patient that flashed on me. I had a nurse that saved me because I had a patient that flashed. She said, he's got new crackles. I'm like, stop. So, and like I said, sepsis remains a full contact team sport.
Correct.
And that's why you have to keep reevaluating. Because if that nurse hadn't, listened and found the crackles, you would have just continued to give.
She saved me. I was never so happy. I was never so happy. I was like, okay, thank you. All right. Because he was actually somebody who I don't think I was going to be allowed to intubate. So I'm like, move it. No fluid for you.
That's right. That's right.
We're done.
Definitely a team sport for sure. Yeah. Well, I think that brings us to the end.
That's right. But we would like to know, what's your anthem song?
All right, I'm going to go old school on you guys.
Yes.
But I think a good uplifting song, because I also do some running, is I like the song by the Foo Fighters from the early 2000s, Times Like These, because I think it's a really good song. It's about resilience. Times like these, you learn to live again, which is it's like get back up, get in the game, because that's really what it is. Times like these, you learn to give again, and and it talks about giving and giving again and getting back up. Plus, it's got a really good guitar riff.
That's awesome.
But it's an outstanding song. But times like these, it's just like get up and get in there, and I think that's pretty much what we do in the ICU. All right. Going to get knocked down, but I'm getting up and I'm getting back in there. So again, if you guys want to go old school, Foo Fighters, Dave Grohl, Times Like These.
I'm going to listen to that after this, actually.
Right.
It's a great running song. It's a great running song.
Yeah.
Great guitar riff. So.
That's awesome.
And for those times when you're really down, suffering from burnout, are there certain things that you specifically do, or is there something that you practice every time you go home, or just on those days where you really had a bad day?
Well, besides Diet Coke and peanut butter crackers, which you guys have seen, I am going to wax a little philosophical. I am a person of faith, and I believe in a God that loves me, my patients, and my whole team. So on a bad day, I do ask the good Lord for his help and say, okay, you got bigger shoulders than me, you take it. Yeah. So I lean on my faith, and then for more secular things, I do like to run. When sepsis slams back, I'm like, okay, I'm gonna run it off, and but also
and listen to Foo Fighters.
And Foo Fighters. So I do, and some older bands that are probably before your time, and then also a good science fiction movie. If you really want to get uplifted, watch the fight scene of Endgame Avengers. So Captain America takes on Thanos.
Yes.
I'll second
so
that.
There we go. There's like, okay, take that sepsis, because I look at fighting sepsis as Captain America taking on Thanos. So
that's very good.
So I was like, okay, yeah, I just tighten up my shield. Go Avengers assemble. So that's I do recommend a good Marvel movie or science fiction movie of your choice.
I love that. Thank you for sharing it. I definitely feel like there's something for everyone in everything that you've said so far.
That's right.
I appreciate it.
We like it. Self-respecting nerds that we are.
Yeah, there you go. We are nerds, self-respecting nerds at that.
Right.
Absolutely.
Well, thank you, Dr. Mullen. I appreciate it.
Thank you, Dr. Mullen.
It's been a privilege. You guys are great. Keep doing the great work that you're doing. I'm so proud of this entire critical care team. And again, it was a pleasure and an honor to be here. And again, y'all, slam sepsis.
Well done.
And that's a wrap.
Thanks.
Yes.
Thanks, you guys.
Thank you for joining us for our very first episode. Dr. Mullen was certainly gracious with her time and knowledge, and we truly appreciate that. Right, Sneha?
Yes, absolutely. Tune in to our future episodes on YouTube and Spotify. Search for @Critical Chats Podcast, and coming soon to Apple Podcasts.
I still like Crit Chat better.
We'll debate about it.